Right, so what I'm going to tell you is two things. You will see a lot of things in primary care or in eye casualty or as trainee doctors which you may not know what's going on when they are related to corneal surgery. So if you understand the surgery that is done, then it will make sense. And then also little tips on how to recognize those things and what you can do in the primary care sector and what you need to refer. These are my declarations of interest. So I'm going to cover, I've got these 4 things listed, but I will just go on till my time runs out. And I'll keep an eye on my time. So the bulk of the talk will deal with cornea transplants because that's the bulk of the corneal surgery we do in Nottingham. And there are different types of cornea transplants. For more than 100 years, there was only one type called full thickness cornea transplant. No matter where the disease is in the cornea, you take the whole cornea out and you put a new one in, and had 16 stitches at least. But now we moved on to lamellar surgery, where you treat only the layer that is affected because it has a lot of advantages. So if the stroma is involved, like in scars, like in dystrophies, or like in keratoconus, then you replace only the stroma, leave the endothelium behind, so you get no risk of failure due to endothelial rejection. It's a huge advantage because the commonest cause of a regraft is failed previous graft. In fact, the commonest cause of a graft today, the commonest indication is a failed previous graft. So that's called deep anterior lamellar keratoplasty. You retain the patient's endothelium, but the rest is exactly the same. You still need those 16 stitches, long recovery period, and astigmatism and distortion of the graft. Endothelial keratoplasty, where the endothelium is affected, the rest is normal. There you just replace the endothelium, and there are 3 ways you can do it: with a bit of stroma, with just the predesmates layer and the endothelium, or with the endothelial descemes membrane only. So when it is with a bit of stroma, it's called descemes stripping automated endothelial keratoplasty, or DSEK. When it is with the predesmates layer and endothelium, it's called PDEC, and with the descemes membrane endothelium only, it's called DMEC. The advantage here is that you're only replacing the endothelium. The risk of rejection is lower than a penetrating graft, but there are no sutures, and the recovery is within 3 weeks because the cornea is the patient's original, the curvature has not changed. It's a very rapid recovery, but the operations are more challenging. Now this is full thickness cornea transplant. So you will see the whole cornea disc is being held with the forceps. This is the first suture going in, and then we do. Nowadays this indication has dropped. It is not the commonest operation we do, but for certain pathologies where all the layers are affected, there's a dense scar through and through, there's acute hydrops after keratoconus or a failed previous graft, then we have to do this full thickness cornea transplant. So what happens, depending on the surgeon preference, you may have different kinds of sutures. So you can see over here, these are the 16 interrupted sutures there. Here's interrupted, 12 interrupted, and a running suture. So you can have only running, only interrupted, or mixed. But this is what the patient can come to you with. They can have epithelial defects, loose or broken stitches, rejection, infection, recurrence of the original disease, and vascularization. So one looks out for all of these, and you will see them, and in the context of a graft they become important. So a loose or broken stitch usually traps mucus, and there is a concentrated fluorescein stain around it. The first very important clue. The second is it acts as a windscreen wiper, this broken stitch that is sticking out, and with each blink it moves, but because the radius is fixed, it can swivel around and make a nice complete circle, as you see over there, that circle, or it may be a half circle. This was the olden days when virgin silk instead of nylon was used, and that is nowadays not used, but classic examples of very loose sutures attracting a lot of blood vessels and causing almost a graft to fail or reject. Here again, loose stitches attracting blood vessels and trapping mucus. Mucus traps polymorphs. Polymorphs cause erosion because of the proteases and also cause inflammation. Here's another classic of that circle that you see. So when you put fluorescein and you see that circle, look for a loose stitch or a broken stitch, because sometimes the stitch has decolorized over time. They usually break around 18 months following surgery, and they become white. So you don't see them easily, but if you put fluorescein and you see a circle, then look for it and you might see this little stitch in the middle. All you have to do is grab it with the forceps and pull it out with topical anesthesia on the slit lamp, which is what we do. If you can do it, fine, do it. Even as a nurse you can do it, but if not, then send the patient promptly for that to be removed, because a loose or broken stitch can cause infection and or rejection. So very, very serious complications. Here's another example of the same. Now, rejection has many different manifestations, and one has to look carefully at the cornea to pick them up. You can reject the epithelium, you can reject the stroma, you can reject the endothelium, or a combination of these layers. So what you see with the epithelium rejection is a line like that and a bit of haze. So this line is the key, and you will see this line again over here. And if you see the patient, one day the line is here, the next day it will move. So it's a migrating line. But the most important point is it stains with fluorescein. So you put a drop of fluorescein. If that line stains, then you know this is epithelial rejection. The eye will be show a bit of redness. The patient will be photophobic. Moving on to stromal rejection, one of the common manifestations is this. This is like adenoviral keratitis. You get these nummular opacities in the stroma, quite discrete from each other. It is not adenoviral because you will see it only in the graft. In adenoviral, you will see in the graft and the host. But rejection will not occur in the host, only in the graft. So if you see these little spots like that, then it's rejection. They are called Kratchmer spots, and they are anterior stromal Bowman's, sub-Bowman's layer infiltrates. Then if you have vascularization of the cornea, you can get edema of the cornea and a lot of inflammation. Then that is true stromal rejection, which you rarely see in the absence of blood vessels. Usually when blood vessels are there, they're usually deep blood vessels. Here's another example of those adenoviral type lesions, but you see them only in the cornea and not in the host rim, like I said. Now, if you see a line like this, and I just told you that's epithelial rejection, but on the slit lamp, carefully you will see it's not on the epithelium, it's in the endothelium, but more importantly, it will not stain with fluorescein because it's inside on the endothelium. And when you see a line like that, which is not staining, and this line will also advance, and that is endothelial rejection. This part of the cornea peripheral to that line will be edematous because the endothelial cells have been destroyed and it's swelling, and then that as this migrates across, the cornea starts getting more and more edematous. That line is made up of series of keratic precipitates, little cells that have deposited cytotoxic cells. Remember I said type 4 reaction, cell-mediated immunity, which is destroying the endothelium. The difference from an epithelial rejection is that the epithelial rejection recovers because the host epithelium grows on and it goes back to normal. The endothelial rejection, the host endothelium does not grow back on, the graft fails. So the problem with an epithelial rejection is if not treated, it can trigger an endothelial rejection. Therefore, they have to be both treated equally aggressively. And here's another very nice example. This is a slide that Dahlia took a picture of one of her patients in Cairo. You can see the little dots are the keratic precipitates, and that's the edema of the graft peripheral to that advancing line. And occasionally, of course, the endothelium and the cornea don't always follow the rules. There can be spattering of keratic precipitates, but all on the graft only. So iridocyclitis, you get keratic precipitates, but you get it all over the host and the donor cornea. You will get it on, but in rejection, it will only be the donor cornea, like those nummular opacities. So again, it tells you this is not iridocyclitis. And it's very severe and acute, then the whole graft will become edematous. So when you see all these kinds of funny changes happening in a cornea graft, immediately refer, because think rejection unless proved otherwise. So what else? Infection, usually related to a broken stitch, but can occur otherwise also, and it's quite devastating because it can cause the graft to fail and or can spread inside and cause endophthalmitis. So again, recognition of bacterial corneal ulcer, just like in any other case, but here in the context of the patient also having a corneal graft. Now, viral keratitis is interesting. We all see dendritic ulcers beautifully in the center of the cornea, but in a graft, you never see them in the center. Usually they occur at the graft-host junction. Remember, you've cut all the nerves, and the virus is in the trigeminal ganglion, so it's coming down the axons, and the shedding of the virus from the axon is at the graft-host junction, because that's where the nerves are trying to grow back into the new cornea. So you get this dendritic staining lesion at the graft-host junction, and that's what tells you that this is most likely to be a viral infection like you see over here. And the original disease, like granular dystrophy for which you did the graft, will come back in the new cornea over time. So it depends on how long after you see, but the difference particularly for granular is that the time we do the graft is through full thickness of the cornea, but when it recurs, it's usually superficial. It starts with the epithelium, starts working its way down into the stroma, and if all is well, the total donor epithelium will be replaced by the host epithelium in 1 year, after which the host epithelium, which carries the defective gene, will start producing the same protein, abnormal protein, which will deposit as granular. So these are some examples where there are superficial recurrences of what was originally a full stromal involvement of granular dystrophy. Epithelial defects and vascularization is common. Now, some of these patients, when you do a full thickness graft or even a deep anterior lamellar graft, the cornea is a bit warped. Astigmatism is there, vision is not good with glasses, so they give them contact lenses, we give them very good vision. Then they don't want to take the lens off. They wear them for 20 hours, 18 hours a day, and that causes hypoxia and vessels to grow. And what you'll see quite interestingly is that this patient with a contact lens with overwear, the vessels will grow back along your suture tracts primarily. That's the first preference. The vessel will grow because the collagen tissue of the suture tract and of the graft-host junction is more vulnerable to protease digestion by the vessels, and they offer the path of least resistance. And you can see here it's illustrated well. There's a contact lens in, but the vessels are growing along this suture tract. They will reach the graft-host junction, and then they can spread along there, or they may go straight in over there. And the problem is that these are not good because they cause inflammation, but in a deep lamellar graft, they do not induce endothelial rejection. They can induce stromal rejection, which is better treatable than endothelial rejection. And then you get extensive vascularization or extensive edema, and that's pretty late stage corneal graft rejection. So all these are the different manifestation, different spectrum of rejection. Now let's look at this operation. What you've done is you injected air in the cornea, a bubble has been created, then you take the top of the cornea off, and the bubble is still intact. Then you puncture the bubble and you cut the remaining bit of the cornea off. So you leave behind what originally was thought to be only the Descemet's membrane. And this was called the deep anterior lamellar keratoplasty, until we showed that it's not the Descemet's membrane, it's this new layer of the cornea, which now has been well proven to be the case. So we're leaving behind the pre-Descemet's layer, the Descemet's membrane, and the endothelium. The pre-Descemet's layer is very tough. It doesn't allow the eye to rupture with little trauma like a penetrating graft might. But that's the operation of deep anterior lamellar keratoplasty. And just to show you this in a human eye bank eye, if you create that bubble, so the eye is upside down, we've created the bubble, you can peel off the entire Descemet's membrane, but the bubble remains intact. So that's this other layer which was missed for many years until we reported it from Nottingham and wrote many papers on this. But that's the histology of that layer. You can see the endothelium Descemet's has been removed, but that thin layer exists, which is the big bubble that is created by the injection of air. Now, how is this different? You can get epithelial rejection, but you cannot get endothelial rejection. So the same thing, you see that line which is staining, and this one does not increase the risk of endothelial rejection because the endothelium is the patient's own. So you can be a little more lax. You don't have to refer the patient the same hour to the hospital. You can call them and say, oh, get there within 24 hours or something, because we can treat this if you know that the patient has a deep anterior lamellar graft, but the sutures will look exactly the same. Now, sometimes you get these interesting features which were previously never seen. So you have, imagine a keratoconus, so a large amount of Descemet's membrane, large cornea because it's ectatic. Now you take the top off, but you still got that lax Descemet's membrane, and the pre-Descemet's layers also stretch. Now you're squashing it all back with a normal shaped cornea. So you get a lot of these striae or these folds or these concentric rings. And these are redundant Descemet's membrane, greater surface area being squashed in. This show you these wrinkles. They're of no consequence. They iron out over time. They don't affect vision. They don't need to be treated. But don't think that they look like the sands of Sahara. Okay, next time it stops, we call it a day, right? So it looks like, for those who've seen refractive surgery patients with LASIK, looks like sands of Sahara. You know, those little bumps, okay. But it's not, because it's something. So just to know what it is rather and not get overexcited. Now, it's not moving forward. You sure it's, there we go. Now often this shouldn't happen, but it happens that in the interface you will see things that look like KPs, but it's not. So this was a patient with deep lamellar graft. And you see that little bit of stuff there on slit beam? This is a bit of your swab tip that has broken off and has been trapped. It was you wash it and all that, but sometimes a little bit stays. Now that bit is annoying when you see it post-operatively in the operation that's gone well, but it's not a keratic precipitate. You don't have to go and fish it out, but it's there, spoils the aesthetic of your surgery and your ego, but over time it does shrink. And you can see it became very small over here, but a bit was still there in that eye. Now, sometimes if the patient has does not have keratoconus, which is a lot of tissue, but has a flat cornea, like a macular dystrophy, and you put a cornea of normal curvature on it, there's a gap between the predescemet's layer, Descemet's membrane on one hand and the cornea. So there's a gap between the two. So when there's a gap, you have to put air in the eye, and this we do quite often, as you'll see with the endothelial keratoplasty, to push the cornea back against the surface. And whenever there's air in the eye, the pressure can go up very high, and if it's not treated, they get this fixed dilated pupil called the Uritz-Zavalier syndrome, and it doesn't come back because there's ischemic necrosis of the sphincter muscle due to high pressure. And in this patient, the graft was attached back, but the pupil suffered that, and then we had to give a painted contact lens to give her normal vision, but that is completely avoidable. Blood vessels will grow in, and like I said, blood vessels follow suture tracks. They will come across this, along the suture track, but the moment they reach the flat plane between the deep lamellar graft, then they start to spread out as a fan. So again, very interesting, the behavior of signs and the manifestation of signs, the behavior of vessels has been changed by the anatomical planes we create by our surgical intervention. This is just example of stromal rejection does occur in deep lamellar keratoplasty. One advantage of this technique is this patient, I showed you the one with the vessels, who used to overwear her contact lenses, got an infection, bacterial infection, the graft opened up. So we thought we'll have to treat the infection and then put another suture in, but now my pointer isn't working. Here it is. So that dehiscence completely settled, and the scar was there once the infection was treated. We didn't have to put a suture because she had a deep lamellar graft. If it was a full thickness graft, there would have been leakage, shallow anterior chamber, and risk of endophthalmitis. So that's another advantage of retaining the predescemet's layer in this operation. Now, moving on to the endothelial keratoplasty, and just to show you what we do. So here, this is the donor eye, not the patient's eye. We're passing a blade to cut at least, if the cornea is 550 microns thick, we want to cut at least 400 of the top off, leaving 150 behind. Then this is the top that's been sliced off with this automated keratome. What's left is what we're going to transplant, because the endothelium with about 130 microns of the stroma. And this is what's being done. Now, just to tell which side is up, this is very gross. This is the first time this was done by a colleague called Dr. Busen. This is his video. So you put this with the endothelial side, but you want to know which side is up, otherwise it will not work. So you put an F. P, F, and S are the only three alphabets that look right one way. If you put an A, it will look right this way, and a B, and so forth. So you then pull this in the eye, and then you can see the letter F the correct way. Now over here, we've taken off the patient's diseased Descemet's membrane. We put this in, you tap it into the center, and you inject a bubble of air to push it against. Now the patient goes around for 3 months seeing a big F. No, he doesn't. It does disappear over time. Now, there's another way of doing this, and this is this pre-Descemet's endothelial keratoplasty. So this is another operation we invented in Nottingham, and there are some centers who do only this exclusively. We just came back from Chennai, Dali and I, where they do only this, and they do 80 operations a day, all operations including this one. So you create that big bubble, you aspirate the air, and then you refine about 7.5 millimeters of that tissue, which is made of the pre-Descemet's layer, Descemet's membrane, and endothelium. And this one has an advantage because it's supported by the pre-Descemet's layer. It doesn't scroll as much as the Descemet's membrane. And this is what you then transplant in the patient's eye. And this is the operation itself. So we've created this bubble, and then what you'll see is we're going to cut it on the side, put some vision blue to stain the tissue. You cut it along the circumference, you put it into this cartridge. It always rolls with the endothelial cell outside. So even if you don't have the F mark, by looking at the way it rolls, you can tell which is the right size. You inject it in the patient eye from which the Descemet's has been removed, and you use air and tapping to open it, put air below it. See, this I was telling you about the air in the eye can cause the pressure to go up, and you have to monitor the pressure, and it's back. And then look at this patient, the air is absorbing. This was the bullous keratopathy for which the operation was done, and when it settles, it becomes absolutely pristine. This was following this PDEC procedure, and again here the pre and post-op, pre-op, post-op at about 1 or 2 months. Now this is the gold standard operation, and here you can see what we're going to do is we're going to only peel off the Descemet's membrane from the donor eye, right? So we peel it off to 2/3, we put it back. Now that F mark here, this is the small F mark with a little stamp, 8 millimeter of tissue is cut. The donor Descemet's membrane is kept aside. The recipient's eye is being prepared. This is the patient's eye. You take out the Descemet's membrane by making a circumferential 9 millimeter scoring and then peeling it off. And then you take this Descemet's membrane, you take it off the disc, you put this dye, wait for about 2 or 3 minutes, transfer it into a bowl, and then you suck it into this pipette and you inject it in the eye. And once it's injected in the eye, you then tap it into place to open it, and then put a bubble of air to support it. So this tissue is only supported with a bubble of air. It can float off. And if a patient walks into your clinic with, my vision is suddenly gone, and you see something blue, this will be blue still in the first 2 or 3 days, then you know that this is what has happened. And it's nothing else other than the blue stained Descemet's membrane that has come off, not a man from Mars. So, but when it works, you can see this is the DSEC operation post-op. So it's a little thicker tissue, and this is the DMEC. Only the membrane was transplanted, and you can see the difference. And patients usually prefer this to this if they've had one in each eye. So we try not to do two different, do the same one in both eyes is better. And what can you see after these operations? What can go wrong? Again, they can have interface debris, as you see those little dots in the top picture over there, those white dots, and you can see at the slit beam, that dot is right at the level of that interface between the tissues. You can see a haze. Mostly with D6, there's an interface haze that can occur because there's more stroma tissue. The keratocytes can overreact and cause that haze. So this can affect vision, but these are the kind of manifestations that will present to people who look at this for the first time or in the primary care. Then you should know what you're seeing. And they can get rejection with the keratic precipitates, as you see. Again, these will be only in the area of the graft. So the rejection risk is much less with endothelial keratoplasty, even though you're transplanting endothelium, but it does occur. And this is the graft that has come off. You can see the slit beam showing you this is the patient's cornea. There's a gap, and then that DSEC graft has not only separated, but it's also sunk to the bottom due to gravity. So if you see that, you know what is happening in this patient. Obviously, we go to take him back, recenter it, and put some more air and try and stick it back in place, and hopefully it sticks. Now, where are we for time? So we've got 5 minutes. Pterygium, I'm not going to tell you much about it other than the fact that when we do the operation, we have this, we stick it in place with glue, and you take a conjunctival graft from the upper part of the eye and you stick it back in place with glue. Now that's called an autoconjunctival graft, and you also stick this part back into place. But what happens post-operatively is you get this reperfusion injury. So you will see the graft that we've detached from the top has been severed of all the blood vessels. So when you put it here, before new blood vessels grow in, those vessels on the graft have suffered hypoxia. Then they connect to the vessels around, and the blood vessels go into these blood vessels, the blood grows into these blood vessels, which are hypoxic, and they suddenly dilate and they exude a lot of fluid. That happens in any organ transplant. It's called reperfusion injury. And then it looks quite dramatic, swollen graft, red graft, but over time it settles. And that's how sometimes it's very hemorrhagic because it bleeds, and the patient comes and we warn the patient, it will be very alarming, it may happen, don't worry, it will eventually settle. So recurrence of pterygium is, of course, a more serious complication that we see in some of these patients. Amniotic membrane, we use a lot of this for various reasons. This is the lining of the baby in the womb. It has very good healing qualities, but there are risks of transmitting HIV, hepatitis B, C, human tissue, and one donor can give you tissue for many, many recipients, so there's a risk of spreading to many people. Different ways in which we use it, but just to show you some example, non-healing defects, you close them with amniotic membrane. So here you can see following herpetic eye disease, there's almost a total melt with some blood vessels. So we put 2 or 3 pieces in it, then put a larger piece on the top, and the cells grow into the membrane and they build up the corneal tissue. As you see in this patient with zoster keratitis, very deep facet in that, you can see how deep it is. We stacked it with amnion, and then when all sutures were out, not only has the thickness increased, it's become more or less transparent with one little bit here that is still opaque. So all these the kind of things you might see, but sometimes this residual membrane becomes opaque and doesn't dissolve. So you can see this patch of white in the cornea and you wonder what it is. Ask the patient, have you had surgery? Said yes. He usually will know that we've done a membrane transplant, and then you can know what's going on in the cornea over here. You wait for it to go, or you then have to go in and remove that. Membrane can fall off and other things, and sometimes ciprofloxacin deposits ciprofloxacin drops that the patient is using, and if there's a defect, it will deposit as a whitish band on the cornea. It will also deposit on the amniotic membrane, and sometimes the spongy layer of the membrane absorbs water and swells, just like Professor Masood showed you could put BSS in the tenons and cause it to swell. The same tissue, the spongy layer swells. It looks like you got a double anterior chamber, but you give it a day or two and that will settle. So these are some of the things. You can get hemorrhage with the membrane and so on. So now if you look at cornea like this, a funny looking cornea, that's because a conjunctival graft has been put to heal this defect, which was otherwise not healing. Even the amniotic membrane might not work. Then you make a flap of the conjunctiva, rotate and stitch that into place. That's what you will see. We'll skip this one. You can close the blood vessels with a fine needle diathermy occlusion, but sometimes the patient comes back with that. So a lot of intracorneal hemorrhage. The patient has had this treatment. Again, you wait, it goes away. And if there are perforations, we put glue on the eye. And this patient might come to you with a white disc like that and some whitish material on the cornea, which is nothing but cyanoacrylate glue that is stuck to the cornea, and then we leave it there, usually covered with a bandage contact lens. So different manifestations of different little procedures that are going on. If the glue stays for a long time, it will attract blood vessels, so maybe it's time to remove that one, otherwise it can cause more damage. So in summary, patients with recent or past corneal surgery may present to primary care with a wide range of issues, right? Understanding the operation helps you understand what's going on. A good history, asking about any recent or past operation, is a very good starting point. So no matter what you see, have you had any operation? Have you had any injury to the eye? Because a laceration, which is like a operation, cutting the cornea, might sometimes produce similar kind of manifestations. And clinical signs will vary according to the operation that is performed. Some signs are generic and some specific to the operation. Sutures are the commonest culprit for irritation, inflammation, and infection. So if you see a loose suture, very often, this is so common despite us hammering this point home. You've done a cornea graft today, the patient's gone home, come back for the first follow-up visit, and in eye casualty, they say, oh, there were 2 sutures loose, but he only had the graft 2 days ago, we didn't touch them. So no, nonsense. These sutures are not doing anything. They're only a recipe for disaster. Even if it is 1 day ago, you take them out and you replace them if they have to be replaced, but you don't leave them. And that's the message we drive home to everybody. If you see a loose stitch, no matter where the patient is, primary care, secondary care, eye casualty, that stitch should come off the same day. Otherwise, it can cause serious problems. And corneal graft rejection, we've seen, has a range of manifestation. Early rejection can save the graft. So we can abort a rejection episode by early treatment. Otherwise, once rejection becomes acute and severe and the whole graft is lost, then it's too late. So sometimes just the time of the day makes a difference. And we tell our patient, if you have symptoms of photophobia, lacrimation, blurred vision, in the morning, come in the morning. Don't wait till the afternoon. Because if we start steroids straight away, we can save the graft. Don't wait for the afternoon. That's how urgent and important that is. Thank you.
Any questions? Got the microphone. And please, any questions for any of the speakers?
We have half an hour for discussion.
Yes,
so,
1 second.
It's going to be a two-way process. We're going to see how much you have understood of all the 6 talks.
Hi. It was about the interface deposits. How long do they usually last, and what symptoms would they get?
It is. I mean, if it's a fiber of the drape, it might last forever. If it's nylon, if it is a material like the sponge material, it's usually made up of a what's it made up of like a polymer or something. Like if it's a sponge, it will last forever. But if otherwise, slowly, the macrophages have to eat it away, and it goes, and it can take months.
And what symptoms would they get? Would it just be glare?
No, they won't get any symptoms.
No symptoms.
It depends. If it is in the visual axis, then they might notice it sometimes. But if it's off axis, they won't even know it's there.
So if we saw that in primary care, I wouldn't really bother about that?
Yeah, if it's off axis, yeah. You tell them you got a little speck in the interface, that'll go away. But if you tell them the surgeon left a piece of tissue, next thing is go to his lawyer.
Okay, thank you.
Thank you. Any other questions? Questions for the audience then?
Yes, so which was the first lecture today? Anybody remembers?
Do you want to say something?
Oh, yes. Okay. Thank you, Prof.
Thank you.
Maybe some background applause